Wonderful. Thank you, Dr. Borman-Shope. And it is my pleasure to welcome all of you to the 30th Annual Nesbit Lectureship and to tell you a little bit about Dr. Mark Nesbitt. Dr. Nesbitt arrived at the University of Minnesota in 1959 to start his pediatric internship and essentially stayed through residency and fellowship. He had a brief stint in St. Louis, but we won't hold that against him, and to join the faculty in 1967, ultimately becoming head of pediatric hematology oncology in 1979. Mark led the way in building a national collaborative group to work together to take the cure rate for children with cancer from almost zero when he started his career to now the majority of children being cured at the time of his retirement in 1996. Mark was a founding member of the Children's Cancer Group that became part of what is now the largest clinical trials network in the world, with over 220 institutions called the Children's Oncology Group, or COG, treating children with cancer. Mark developed the first clinical trials for Ewing sarcoma, acute lymphocytic leukemia, and a rare disease called histiocytosis. Mark was the first North American president of the Société Internationale Oncologique Pediatrique, the international equivalent of the COG. It is because of Mark's leadership in the field that we now take for granted the amazing national and international collaborative work that is routine to advance pediatric cancer research. Deeply important to Mark is the ongoing education and training of the next generation to build on the success of the past. Since the fellowship started at the University of Minnesota under Mark's leadership, over 100 individuals have been trained in pediatric hematology oncology and blood and marrow transplant. Mark's legacy and the success he is most proud of is that of his trainees. All of us, including myself, who trained at the University of Minnesota, are standing on the shoulders of the giants in the field who have gone before us, namely Dr. Mark Nesbitt and many, many others. 30 years ago, the Nesbit Lectureship was established to honor Mark's legacy. Sadly, last year and this year, due to the pandemic, we had to adjust to a virtual lectureship without the usual celebration events, and with Mark and his wonderful wife, Deb, safely staying in Arizona. In honor and recognition of Mark's legacy and commitment to training in pediatric oncology, the annual Nesbitt Fellowship Award was established 7 years ago. This award was created to ensure a fellow in pediatric hematology oncology has the opportunity to attend and participate in an international meeting to advance their career, as Mark experienced through his many international collaborative relationships during his career. Even though we are not having our normal lectureship events, we are thrilled to be able to award the 2021 Nesbitt Fellowship Award to Rhonda Ademily for travel to the American Society of Pediatric Hematology Oncology meeting in May 2022, hopefully held in Pittsburgh, Pennsylvania. And yes, this is not international, but international travel is not really even possible to think of right now, where she plans to present her work. Dr. Ademily is currently entering her 3rd year of fellowship. She is planning on presenting her work on the use of acupressure therapy to aid in neutrophil recovery following chemotherapy. She is working under the mentorship of Dr. Lynn Gershon. Ultimately, she hopes to pursue a career in pediatric hematology oncology and integrative medicine. She plans to actively participate in the ASFO, Integrative Medicine Interest Group, while at the meeting. Join me in congratulating Dr. Rhonda Ademily on this fantastic award. Now on to our grand rounds. I am thrilled and honored to introduce today's grand round speaker, Dr. Joseph Neglia. Known to many, Dr. Neglia is the Ruben-Bentson Chair and head of the Department of Pediatrics at the University of Minnesota and the physician-in-chief of the M Health Fairview, University of Minnesota Masonic Children's Hospital. He is a graduate of the University of California, Irvine, the Loma Linda University School of Medicine and received his training in pediatrics at Baylor College of Medicine. He then came to the University of Minnesota, where he completed his fellowship in pediatric hematology oncology and earned a master's of public health. Dr. Neglia has been a pediatric oncologist at the University of Minnesota for over 30 years, focusing his research in the area of cancer survivorship. He is a national and internationally known expert in the field and a key leader for the Childhood Cancer Survivor Study and the Children's Oncology Group, standing on the shoulders of Dr. Nesbitt. It is deeply fitting that Dr. Neglia, who trained and worked with Dr. Nesbitt for many years and followed Dr. Nesbitt's lead in focusing on education and clinical research, is the 30th Nesbit Lecturer. I look forward to his presentation entitled Childhood Cancer Survivorship, 30 Years of Care, Research, and Education. Dr. Neglia.
Great. Thank you, Brenda. Thank you for the very kind introduction. I'm going to share my screen. And hopefully this looks okay. Emily or Brenda, can you nod?
Yep.
Looks great.
All right, great. So thank you everyone for being here. I want to extend a special welcome to our new intern class. Congratulations. We are very happy you chose to be with us at Minnesota, and I very much look forward to seeing you on the floors and in the clinics over the coming few years. So welcome and thank you for being here. All righty, let's try and get this to go. So as we get started, I want to thank a few people who have helped pull this thing together. I think Emily Borman-Chope asked me earlier this morning how many talks I get to give that aren't related to the department head job, and it's not that many. So I turned to get some help from a lot of friends, including several people here, Dr. Lucy Turcott, Kareem Sadak, and Bruce Blazer, and then Greg Armstrong and Les Robeson of St. Jude's Children's Research Hospital. And most of all, Dr. Nesbitt, thank you for everything you have done. I also want to take this opportunity to thank the Children's Cancer Research Fund. CCRF is celebrating its 40th anniversary this year. And as many of you know, and many probably don't, CCRF came into being when Katie Hedgebeck, at that point, a little girl with leukemia, decided she wanted to donate her money that she had saved for a bicycle to research so that other children didn't have to have cancer. Katie and her parents, Norm and Diana, and a lot of friends have worked on this goal for a long, long time and have hit it out of the park. And we just want to again say thank you. Over these past 40 years, CCRF has donated over $100 million to childhood cancer and blood and marrow transplant research at the University of Minnesota. So for any of you members of CCRF who are on here, thank you very much. This has been key to a lot of what I will talk about today. So Dr. Weigel went over a fair amount of the basics of Dr. Nesbitt. His break in St. Louis was 2 years of the Army of service in the U.S. Army as the post MD in St. Louis. Mark came back, joined our faculty, made one of the fastest rises to professor I've ever seen. Looks like it took him about 6 years, and then led the Hem/Onc division for many, many years. As Brenda said, he served as vice chair of the Children's Cancer Study Group that eventually grew into the Children's Oncology Group. And he chaired one of the key trials in acute lymphoblastic leukemia, CCSG 101, which was one of the first national trials to report more than 50% survival for childhood ALL. Mark's had multiple international and national recognitions. He's received the Distinguished Career Award from the American Society for Pediatric Hem/Onc, the Outstanding Achievement Award from the American Cancer Society, and just numerous accolades, and they're all well-deserved. Beyond this, Mark is a clinician, and you know, I was very fortunate to have been able to train with Dr. Nesbitt back in the 80s, really when We were still writing with notes in charts with pens. The pace seemed a little less harried. And we had a fair amount of time to actually spend with the kids. And this is Dr. Nesbitt with a patient of mine actually from that time, a young boy who presented at 18 months with leukemia, had a very high white count. Unfortunately, this child went on to relapse. He then had more chemotherapy followed by a bone marrow transplant and is now 28, 29 years old and working as a geologist. Mark was a thoughtful and very patient clinician, and I think you can get that impression in this picture. Dr. Nesbitt was also a little bit of a chemist, and he had a knack for pulling people together. This is a picture. It was hard to find pictures of Dr. Nesbitt on the internet. This is a picture that Les Robeson turned up of a bunch of us probably sometime back around 1984, 85. You can see Bruce Bostrom, Chet Whitley, Les Robeson in the top row. That person wearing a shirt that I never recall owning is me. Ralph Shapiro, the immunologist, and then Dr. James White, a hematologist and actually a platelet expert. As Brenda mentioned, Mark touched a number of people, and this is just an incredibly small listing of some of those names. They include Dr. Bill Woods, who led the program here for many years and before moving on to Emory University in Atlanta. Our own Dr. Bruce Blazer and Norma Ramsey. Norma led the bone marrow transplant program here for a number of years. Bruce, as many of you know, is still a professor in the Department of Pediatrics and leads a CTSA grant. Leslie L. Robeson from St. Jude, again, faculty member here for many years and now at St. Jude. John Parenthesis, who chairs the Hematology Oncology program at Cincinnati. Smita Bhatia, who leads that program at University of Alabama in Birmingham, and many, many more. So Mark's had an incredible reach. So the goals for the talk today really are straightforward. I want to talk a little bit about survivorship and childhood cancer, talk about major innovations and investigations that have happened over the past 30 years. I think that's very appropriate to do at the 30th anniversary of the Nesbitt Lecture. Again, the things that I will hit, and I'm just going to share 3 of them, are my own thoughts. I'm sure everybody could challenge them. There are a lot of hugely important things that have happened in survivorship. And then we'll end talking a little bit about our future challenges. So this is a slide that I think every pediatric oncologist probably shows at the start of every one of their talks. This slide illustrates the dramatic achievements that have been made in survival of children with cancer. This is from SEER, the Surveillance Epidemiology and End Results Program of the National Cancer Institute. And it shows that back in 1975, child diagnosed with cancer had probably about a 55–60% likelihood of 5-year survival. That number is at 85% now. For some diseases, such as childhood leukemia, this has been an incredible journey. If you look at this slide, you'll see the light pink line here at the very bottom is what was going on in 1968. Dr. Nesbitt joined the faculty right around 1969. Most children, 90% of children were dying of their leukemia at that point. The early chemotherapy success started to put kids in remission. We saw improvement in the early 70s. But then really this gap, this huge gap here and jump here was made up by better chemotherapy, better regimens of chemotherapy, and then the use of sanctuary therapy. So treating the central nervous system, treating the spinal fluid. This focus pushed us up above 50%. Right now, probably 95+% of children with acute lymphoblastic leukemia go into remission. And for some subsets of leukemia, we expect well over 90% survival. This is another way of looking at this more broadly for across children with cancer. This looks at the death rate due to childhood cancer over the last several decades. And you can see the high death rate in acute lymphoblastic leukemia dropping very quickly, improvements for brain, improvements for non-Hodgkin's lymphoma, improvements for kidney and renal pelvis tumors, Hodgkin's lymphoma, and then kind of a fairly flat for some of our sarcomas and bone and joint tumors. But really overall remarkable achievements. And this all has put us into a place where we really treat children from the beginning for cure. I can't think of many times over my time as pediatric oncologist where I have started the conversation with, we don't think we can cure this. We may not have the best statistics, but over my career, I've seen the survival from stage 4 neuroblastoma go from about 10% to 60%. So I'm very, very positive when I start out with a new patient that we have a reasonable chance for cure. And that involves very aggressive therapy sometimes. The result is that over 85% of our patients diagnosed each year are going to be 5+ year survivors. And an estimate in 2018 suggested that over 480,000 childhood cancer survivors now alive in the United States. And that's probably over 500,000 today. So childhood cancer survivorship has become the rule rather than the exception. Therapy has not eased for many subgroups. In fact, it's intensified in some places, but been relaxed in others. And it's incumbent on us to figure out ways to care for these children. So we all know, but Mark knew this before the rest of us seem to, that reaching a 5-year mark, having your end of chemotherapy day is not the end of your journey with childhood cancer. We also came to realize that our cooperative clinical trials groups, things like the Children's Cancer Group, the National Wilms Tumor Study, the Pediatric Oncology Group, really were focused on short-term outcomes. They were very interested in what happened over those first 5 years. They wanted to understand the toxicities of the drugs that they were using, but the ability to follow these patients long-term really fell apart after about 5 or 6 years. And I remember seeing data years back that suggested that by 10 years out, the group was really only following about 10% of the patients that had been participating on their trials. So this 10-year mark was a real problem as we were seeing children now survive 10, 20, 30 years from their cancer diagnosis. So little information was available and we needed to start looking for ways to do something. So my first choice for the innovation and investigation is the Childhood Cancer Survivor Study. This is Les Robeson. As I mentioned earlier, Les is a graduate here of the University of Minnesota. He completed his PhD in 1982. Les's PhD thesis was on a children's cancer group study called 101L. So I showed you that slide a little bit ago where there was that big jump in survival from about 30% to 55%. That was built on CCG 101. 101L was a study that was conceived by Dr. Nesbitt and other colleagues at the time that was going specifically to follow up these children with leukemia, receiving a lot of different versions of radiation therapy or chemotherapy to treat their cancers. So the Childhood Cancer Survivor Study came into being under Les's leadership here at the University of Minnesota. A number of us participated in developing a pilot study. And Les and Mark and others went out there to recruit the participating centers. Single institution studies were starting to be reported at the time, but they suffered from small sample sizes and really a lack of heterogeneity of the exposure. As I mentioned, the lack of extended follow-up of these childhood cancer survivors was incomplete. Follow-up was mostly passive. And when you have passive follow-up, the people that come back to clinics are often the people that need to come back for clinics. So we were concerned we were overestimating the number of serious effects, or possibly totally missing some less major effects. The other thing that Les realized as this was coming to being is that in many cohort studies, as you put together a cohort, you struggle to understand what the exposure was. Say you're trying to look at an exposure in radiation in power plants, or an exposure to chemicals in a chemical plant. You often don't know what the doses are. You don't know what the exposure really is. We have very clear documentation of our exposures for children who undergo cancer therapy, because we write those exposures out in the chart. Our nurses put them in MARs. We develop surgical notes. We have radiation therapy reports. We have that documentation of our exposures of interest. So the Childhood Cancer Survivor came into being. It was originally funded in 1994. It was a retrospective cohort. And when we started off, we in about 1994, we had a plan that said if you were diagnosed between 1970 and 1987, and you were alive at the 5-year mark, you entered into the survivor study. You were eligible for the program. It was not for people that had never relapsed. It was not for people that were well. It was alive at 5. It included the major diagnoses of childhood cancer, leukemia, lymphomas, brain tumors. You'll notice that we're missing retinoblastoma, we're missing hepatoblastoma, we're missing germ cell tumors. The retinoblastoma was a deliberate omission because of a similar study that was forming up. The other ones were dropped because frankly, the budget got nicked. And that's one of the things all of us have had to deal with over the years, is trying to bend and fit our research goals into real budgetary constraints. As I mentioned, we extracted very detailed treatment data on these patients. We individually reviewed all of their medical records. We had their radiation therapy reports sent to MD Anderson, where that data was coded. We collected operative notes. And we have done this now for over 25,000 participants, 14,000 coming from that initial cohort, and 11,000 from an expansion we did that took us all the way to 1999 and 3 decades of treatments. These are our participating centers. It's a very big study that is now run by Dr. Armstrong at St. Jude Children's Hospital. Also want to thank Greg for sharing these slides with me. But this is the group. It includes, it's an international group. We have a couple of Canadian sites, but it's primarily US sites from around the country and some of the largest centers in the United States. Oops. As you would expect in a survivor trial, most of our survivors had leukemia. It became one of the first childhood cancers that was survivable and contributes about 40% of the cohort. But you can see that there's a pretty broad number of patients across the board here. And there's decent representation of Hispanics, African Americans, not as good as we had hoped, but we do have a reasonable number for analyses of impact of race and ethnicity. So the cohort was constructed from the selected childhood cancer diagnoses between 1970 and 1999. Everybody had to be under age 21 and English or Spanish speaking. After informed consent, the families or the patients completed a very detailed questionnaire or were interviewed by phone. Treatment information was extracted from the medical records. We collected biologic specimens. We collected buccal cell DNA and blood on selected individuals. We have gone through and confirmed all the reports of second malignancies in these individuals through pathology reports. I really need to give a shout out here to Lucy Turcott, who has spent an incredible amount of effort in doing this. It has really been an amazing resource that has fueled a lot of our work within the Childhood Cancer Survivor Study. We've also created a repository for tissue specimens from those second cancers in Columbus, Ohio. We search the national index periodically for survivors to make sure that we are not missing anybody. Usually we hear from the family members if something's happened to that individual. And we've created a sibling cohort that is a random sample of siblings throughout the cohort study who have gone through the same questionnaire and also contributed biologic specimens. This is an idea of the undertaking. Started with collecting our baseline data back in 1992. First follow-up study began in 2000, second follow-up study 2002. We're now on study follow-up number 7. We've collected buccal cells over the years as well as on the expanded cohort. And the grant has morphed from a cooperative agreement to a resource grant. And this is important because the Childhood Cancer Survivor Study is not a study that belongs to a small set of researchers. It's available to researchers across the United States and actually around the world to use the data, use the specimens, and to generate their own research using the resources of the Childhood Cancer Survivor Study. This is where our participants are. You can see there's a huge cluster around Minneapolis. That's where this was basically started to grow up. So Mayo, Children's of Minnesota, us are all part of this. Very strong East Coast representation. We actually have a number of patients from Hospital for Sick Children in here as well. And then good representation along the coast. So we have 31 individuals, as I mentioned, over 38,000 survivors, and this is an open resource. This has been an incredibly productive resource. We've had over 363 abstracts, probably as of today, because these slides are a few weeks old now, probably at about 400 publications and have been cited over 26,000 times. We've had the involvement of over 1,200 investigators, including 91 early career trainees. As I mentioned, within the survivor study, we've had 60 investigator-initiated programs launched that have received an additional $69 million in grant support. So what have we learned? Well, we learned something very, very quickly in the survivor study, and we learned that our patients were dying a whole lot faster than the US population. This graph depicts the mortality after 5-year survival for what would be a standard survival in the United States for this age group, and then what we were seeing. So you can see males and females had basically continued loss of life, even up to 30 years. We're growing further and further away from people who had not had cancer. For many of us, it was a little bit of a surprise that the leading cause of death was recurrence of the original cancer, accounting for 58% of all deaths after 5 years. But other late effects were taking their toll. New cancers were occurring, deaths from new cancers were occurring 15 times higher than in the background normal population. Death from cardiac disease, 7-fold higher. Death from lung disease, almost 9-fold, and multiple other causes as well. This is what it looks like graphically. You see very high risk and acceleration of risk during the first 10 years, and then it starts to taper off a little bit. But that mortality starts to rise as you get further out from second neoplasms, from pulmonary complications, cardiac complications, or other health complications. And this was one of the more telling slides that we created. And it really shows that by 30 years out, deaths from essentially toxicity of the chemotherapy or the radiation therapy now surpass deaths coming from recurrence or progression of the original disease. So we clearly have we clearly have problems out there, and we very clearly need to address those. These aren't all life-threatening problems. Many patients have chronic conditions, and many patients have severe chronic conditions. And this is data from Kevin Effinger, who's now at Duke University. Kevin is a family practitioner, family medicine person who was part of the adult survivorship program at Sloan Kettering when he started his work with us. Kevin and his group reviewed and coded chronic self-reported conditions by our survivors and a sibling control group. They used something called the Ctcae Coding. This is a cancer treatment coding system that's been developed specifically to collect information about adverse outcomes in patients undergoing treatment or surviving cancer. And there were 3 primary outcomes: the occurrence of any condition, grades 1 through 4, severe life-threatening conditions, grade 3 or 4, or number of survivors who had multiple conditions. And here's some of the results of that. This was published in the New England Journal back in 2006. You can compare the survivors and the sibling cohort and see that over 26% of these survivors had grade 3 or grade 4 chronic conditions, as opposed to about 5% of the sibling cohort. In addition, well over 50% of the survivors were reporting multiple health conditions, as compared to just 18% of their siblings. This did not skip any particular disease. We saw an increasing incidence of survivors from across all grades, as well as across the severe grades for all diagnoses: leukemia, brain tumors, Hodgkin's disease, neuroblastoma. We clearly have a dichotomous population. It's not been all bad news in this. We've been able to use the survivor study to actually show improvements in survival as well. This is work that Dr. Turcotte did a few years ago, looking at the temporal trends and subsequent neoplasm risks between 1970 and 2015. This was published in JAMA in 2017. We were able to collect over 370,000 person years at risk in the group. And over that time, we had 1,639 survivors who had developed a total of 3,300 second neoplasms. This included over 1,000 malignant neoplasms, 233 meningiomas, and over 1,800 non-melanoma skin cancers. We were able to show changes in treatment exposures over time by decade. 77% of the kids treated in the 70s had therapeutic radiation as part of their treatment plan. That had fallen to 54% in the 80s, and then down to 33% in the 90s. Conversely, exposure to chemotherapies went up. And you can see exposure to alkylating agents, these are drugs like cyclophosphamide and ifosfamide, rising considerably. And the use of other drugs like epipedophylotoxins also increased. So the trade-off was actually good in this regard. If you look at the attained age of survivors to essentially put them into groups that are analyzable, you can see that patients in the 70s had a decline in the standardized incidence ratio of new cancers over time, but still remained elevated. Compare that to the 90s, where it starts off less, and stays less. So we really did show that we're able to make a difference over this time period, mostly by removal of radiation therapy. The analysis showed that after you adjusted for everything, including diagnosis, demographics, the rates decreased in every 5-year era. Treatment exposures, by adjusting for treatment exposures, you actually attenuated that decrease, certainly indicating that decline was due to changes in treatment exposure. We showed this across all categories, males and females. We showed an increased risk of second neoplasms with radiation across all categories, and an increase in risk with increased doses of cyclophosphamide and high doses of epipodophylotoxins. So by 30 years, we've shown that the diagnosis, the risk of death from a late effect actually exceeds that of the original diagnosis. No system is spared. We've got chronic conditions that are prevalent in this population. And second cancer risk is very real and a leading cause of our mortality. So next step, what's the second important innovation? Survivorship clinics and follow-up guidelines. So over the past 30 years, dedicated survivor clinics have become near universal in pediatric oncology programs. In the early 1990s, Dr. Nesbitt, Dr. Alan Gammas, who was one of the fellows here at the time, Barb Rutcher, a nurse, and I went to Children's Hospital of Philadelphia to review their clinic. Dr. Anna Meadows and her colleagues there had really taken the lead in starting a long-term follow-up clinic. And we went to spend a few days at CHOP to learn a little bit about their program. With support from grants, with support from the Children's Cancer Research Fund, we initiated a multidisciplinary clinic here that included med pediatrics physicians. Actually, Brad Benson was our first physician for the clinic, endocrinologists, radiation oncologists, and many others. This really has become the standard. And the Children's Oncology has surveyed the group a couple of times. This is data from the 2007 surveillance or survey. 81% of the institutions at that time were offering survivor programs. This had grown to 87% years later, with over 59% having a dedicated survivor clinic, 40% doing it in the oncology clinic. In almost all instances, there's in 68% of the time, they're providing a survivorship care plan. Many of these clinics hold on to their patients. They do not have an easy transition. And this is a lesson we are learning across a lot of medicine, is that as we do better with children with chronic diseases, we need to find effective transitions. Eligibility for most of these clinics, typically around 2 years off therapy. We do a lot of this just based on what we know about chemotherapy regimens. Most of the patients have ALL. Most of the patients come off successfully after about 2 to 3 years of therapy. So 2 years down the road puts them right around 5 years. As I mentioned, many of these programs do not have good ways to transition their survivors. So they actually are open to patients of any age. And that includes us. We will see patients of any age in our survivor clinic. Dr. Sadak runs this clinic. But we will see them in the clinics and surgery center on the East Bank, so they can be closer to the medical specialists that they may need. We still have a ways to go to make sure that all of these patients are getting seen. This is, again, this Children's Oncology Group experience, but this suggests that over a quarter of our survivors are not getting into survivorship programs. And this is really a problem. These programs are essentially personnel intensive, always typically using an oncologist. Our nurse time, social work is very important, but all these people need to be identified and brought into this to help develop these clinics. These clinics actually generate treatment summaries that they give to the families. These are incredibly helpful as kids go on, they grow up, they go to college, they move away. Other educational materials, and then summaries of those visits. So at this point, with a relook at this data now, most recently, 97% of institutions are now have a dedicated program. 75% have dedicated survivor clinics as opposed to where it was in 2007, and 88% are giving treatment summaries. Our transition patterns are for AYA patients haven't changed. We have yet to actually get this right. And again, at most institutions, we still have over 25% who are failing to access this care. So research regarding more efficient strategies is needed to make sure that all survivors have the opportunity to get the appropriate and equitable care. So a second part of this is follow-up guidelines. So we're seeing predictable events, and these events are excellent targets for screening and individualized care. The protein nature of these late effects mandates review of multiple organ systems, neurocognitive, psychosocial, and other domains. And these recommendations need to be data-based, peer-reviewed, and periodically updated. So enter the Children's Oncology Group Survivorship Guidelines. This is just a snapshot off the website. You can just Google this and find it. It's very easy to go into. It's not password protected. These are open to everyone. We are now on version 5. This has been going on for a number of years now. These guidelines were just reviewed and republished in 2018. This program originated in the Children's Oncology Group in the Nursing and Late Effects Committees. And Wendy Landier, whose name you see near the bottom, who was leading the nursing group at that time, and Smita Bhatia, who was leading the Late Effects program, did an excellent job of bringing these into being. These guidelines provide evidence-based and experiential-based recommendations for over 155 therapeutic exposures. This started in 2003. We're on 2021. We are on version 5. The core committee still includes Wendy Landier in nursing, Smita Bhatia, who I mentioned as one of Dr. Nesbitt's fellows, Melissa Hudson from St. Jude, and Sandy Constein from Buffalo, our radiation oncologist, are all the current core committee. So this is an effort of well over 100 people. The guidelines are available on the web, and they are immensely helpful in developing care plans for survivors. This is the Anthracycline exposure guideline. It talks about the anthracycline's antibiotics, but then provides a way to actually understand the relative cardiotoxic dose of the various formulations. Then goes on to recommend echocardiograms, other screening, and those based on the exposure to radiation, and the frequency recommended. So these are incredibly valuable in following up patients. This is the guideline for breast cancer screening. You can see for women that are receiving radiation to their chest, axilla, or TBI, the guidelines are recommending mammograms yearly, beginning 8 years after radiation or at age 25, whichever comes last. And more recently have added the recommendation for breast MRI as an adjunct to mammography. The guidelines are not only physician-focused, they are patient-focused, and these health links have been developed by the group. We now have 43 of these that cover everything from amputation through thyroid dysfunction that really speak to concerns of the individuals. These include things on financials, how are you paying for your care, healthy advocacy, healthy lifestyle, and advocacy. So this is a huge resource that has been developed over time. The third innovation I'd talk about is something that I've been very fortunate to see in my career, and that is a broad multinational collaborative research plan for survivors. So again, survivor phenomena is not only a US event. Collaborative work preceded the funding of the CCSS and continues to this day. And this work is extending across multiple areas, all the way from the molecular biology, population sciences, transition sciences, and a wide range of disciplines. So this is one of the very early papers from something called the Late Effects Study Group. This was published in The Lancet in 1982. And this looked at the incidence of second neoplasms in children. This is Anna Meadows, who I mentioned earlier, Dan D'Angio, actually, who was a radiation therapist here years ago before he moved to CHOP, and Valerie McKay from the biostatistics program at Sloan Kettering. They looked at near 15,000 patients across a number of institutions in Europe and the United States, and were able to show an elevated risk of cancers. In particular, a big focus around Hodgkin's disease. Dr. Bhatia looked at this back in 1996, showed this rise in cancers, but more importantly showed that essentially by 40 years of age, 35% of our Hodgkin's survivors had developed breast cancer. This is new data. This is data from Tara Henderson at the University of Chicago, looking at the experience we've had over these decades in the survivor study. And you can see a very nice reduction of that risk, driven in large part by limiting radiation therapy. But, naturally there's a but, we're seeing an association develop now with anthracycline exposure and breast cancer risk. And you can see a relative risk of 3 for dose of anthracycline doses over 250 milligrams. Just adding chest radiation therapy in takes that relative risk to 7. Starting to add anthracyclines increases that even more. As I mentioned, this is about a group working together. So this is just part of data part of slides I got to present a few weeks ago at one of our meetings. This is also breast cancer work. This is from Lenny Wong at City of Hope, looking at cost effectiveness of breast cancer screening. We're now recommending this for thousands of women. So she looked at the COG guidelines, did some simulations of 5 million chest irradiated Hodgkin survivors using different screening methodologies, and modeling treatment-related breast cancer risk and survival from the Hodgkin's lymphoma cohort in the CCSS. She concluded that annual screening is beneficial. Mammogram or digital breast tomosynthesis are the most cost-effective, with cost-effective ratios of less than $100,000. And MRI added, but maybe didn't add enough to reach a cost-effective level. So again, this is data that will be reviewed by the Guidelines Committee as we develop it. Chaya Moskowitz at Sloan Kettering has developed a predictive model. This model actually is available now, was just published, available on the internet. You can actually, for your survivors, enter things like the age, how much radiation they received, menopause status, anthracycline exposure, age at receipt of radiation therapy, and family history, and it will give you a risk. In this instance, with these characteristics, a risk of about 10% by age 40. You change it, change the anthracyclines from no to yes, the risk goes up. And you can see this, and you can use this on a personal basis as you're counseling patients. The other part of this that becomes important is how are we treating these women? These are women that had, Hodgkin's disease. Many had alkylating therapies. They had anthracyclines. They had, pretty extensive radiation. How are you going to treat their breast cancer? Lucy Turcotte is investigating this and has assembled over 432 cases of breast cancer, breast cancers developing in our survivors, and has abstracted those records for therapeutic plans. So these are not kids anymore now. These are young adults, not young adults, but adults, and sometimes older women who are getting treated for breast cancer, where she is going to compare those to controls from Minnesota, Chicago, and Duke to try and understand how we're treating, and are we effectively treating the breast cancers that have occurred. Data I'm not showing shows no, the risk of dying for developing a secondary breast cancer after childhood cancer is higher than it is for de novo cancer. And Dr. Turcotte's working to figure out why. So 30 years from now, where are we going to be? First thing that's important is everything we have talked about, I guess I have talked about, for the last 40 minutes has been the outcome standard cancer therapies, many drugs, many things which have been around since the 1960s. All the amazing change in ALL was taking a group of about 7 drugs and learning how to use them effectively. Doug Hawkins, the chair of the Children's Oncology Group, did a seminar several months back, talked about, it was his birthday when he did it. He said, I was born in 1964, and that was the year Vincristine was approved. I was born a whole bunch of years before 1964, and it was even less. It's been a incredibly challenging thing to see new drugs get brought forward to children, though we're now seeing that happen. And these are drugs like monoclonal antibodies, things that upregulate the immune system. We're seeing targeted kinase inhibitors and many, many more. We don't know what those drugs really are going to do in the long run. And follow-up, though challenging, and it has gotten more challenging in the 2010, 2020s than it was in the 1990s, is tough, but more necessary than ever. So I want to close with just a few final thoughts here. And this is, I think, a question we should be asking and really working our best to come up with the answer. And this question is 5-year survival the correct endpoint for a 5-year-old? It's great that 90% of them are 5-year survivors, but where are they going from there? And how are we going to best assess the cumulative burden of chronic conditions and late mortality? So this is a paper that has been e-published, but not hit the real print yet, from Williams et al. At St. Jude. And the statistician that's leading this is a man named Yutaka Yasui, who I've worked with for 25 years now. It's just brilliant. They're attempting to answer this and help get data to guide us. So they have gone and looked at SEER data for 445,000 individuals who were diagnosed with cancer under the age of 20 between 1975 and 2016. They estimated that 126,000 excess deaths occurred in this group of 445,000. And then what they did that is straightforward, innovative, and important is they categorized them, those deaths, as if they occurred between years 0 and 5 from diagnosis, it was likely the primary disease. 5 to 10, probably a mixture, and 10 plus years likely due to treatment exposures. This is a little hard to read, and I'm going to take you through it as best I can. This blue color is the earliest mortality. This green that's a little harder to see is the 5 to 9, that intermediate mortality. And then the red is the excess deaths, late deaths. And as you can see, in ALL, very few late deaths. I'm just having trouble getting the, just go down here. If you look at the group overall, you see this nice reduction over time of early mortality. And this is what we've been talking about, 5-year survivorship. It looks better and better and better. If we add in the intermediate group, it still looks pretty good. That intermediate group has stayed pretty flat. But when we add in the late group, the 10 years plus, this nice downward slope gets attenuated a whole lot. And that is a huge concern. And this is being driven out of this very late mortality. This is not the same for everyone. These are ALL survivors. Again, that nice 5-year drop, actually improvement in the mid-years, and maybe some headway starting now for the very late ones. But for brain tumors, for Hodgkin's disease, it seems that in many ways we are trading time and just pushing out these very serious adverse events to later years. So there's clearly work to do. And this, I think, is one of the most graphic illustrations I've seen of that. So finally, I just want to thank Dr. Nesbitt for accepting me into the fellowship here in 1983, 84. This has been a wonderful place to develop as a pediatric oncologist, and a wonderful place to develop the collaborations to actually do the research, deliver the care that kids like Lucas here so much deserve. With that, I will end, and we should have a few minutes open. So thank you.
Thank you so much, Dr. Neglia, for an amazing 30-year journey and really painting the landscape of the challenges ahead of us. And I I agree. That's probably one of the most graphic presentations I've seen of that ever. So thank you for that. If anyone has questions, please jump into the chat. And Joe, I'll start by saying, what do you think was one of the biggest challenges of trying to pull together something as large as the survivorship study, an effort at that scale? What do you think were some of the biggest challenges?
I think we had to convince the NCI we could do it. That was a big challenge. We were talking about individually, you remember, I mean, this is 1990 something, individually hand abstracting over 10,000 records across the United States, delivering all the radiation films to MD Anderson. Really, the logistics were a huge piece. The grant was funded it's been a long time since that first site visit, but the grant was funded, I believe, after the initial site visit. If Les is in the chat, he would probably know that better than me. But yeah, I think that was a huge challenge. We had getting contributions, once it was going, getting contributions from all the institutions was challenging. But all in all, people worked together incredibly well to create this, and they've stuck together with it for years and years. Mm-hmm. Biggest challenge right now is finding survivors. With the advent of cellular phones, people who don't look in their mailbox for things, it's just finding the patients is really more challenging than it was 30 years ago.
Mm-hmm. Dr. Turcotte has put in the chat, great talk, Joe. I think a huge challenge is that the people developing therapies are not the same people studying late effects. We often work in silos. How do you bring these groups together at the time of therapy development to help reduce late effects?
Yeah, thank you, Lucy, for the softball pitch here. This is tough, and it has been aggressively worked over the years. We actually tried a long time ago. I was the head of the late effects committee in the COG or CCG, I think back then maybe. And we actually tried to have one representative of late effects on every study committee. And I still think those people are present, but I don't think they are quite heard as well. Also, our data wasn't as good. I think the data that's been developing now around chemotherapy exposures, some of the stuff Lucy's shown and other people have shown around anthracycline exposures, being more than just heart issues, are hugely important. I think we just have to keep talking to each other. The people that are doing late effects need to also stay engaged in the development of upfront therapies. It's just not an easy thing to do.
And I will give the last question here to Dr. Brandon Nathan. Dr. Neglia, are there additional differences in survivorship, comorbidities, or rates of follow-up among our patients of color? What efforts do we need to make to eliminate inequities that are present?
Yeah, I don't know that data probably as well as I should have off the top of my head. The challenges in finding people to participate in these studies is greater in people of color than it is across the Caucasian white population. So finding that data is important, and getting people to participate is important. You saw even in the survivorship cohort right now, we don't approach the national benchmarks for non-whites. And that's because we have trouble finding people, and we also have trouble convincing them to join these studies. That said, there is some suggestion of increased morbidity in the non-Caucasian population, and it's a hard group to work with right now. but there is a lot of work going on to address those things. I'm sorry, Brandon, I can't give you much better than that right now.
Well, with that, I want to thank you, Dr. Neglia, for an amazing presentation, for honoring Dr. Nesbitt on the 30th anniversary of the Nesbitt Lectureship. It is amazing that we're at 30 years. So and just a huge testament to decades of work, collaboration, and really demonstrating how working together we can truly make a difference in the field, and truly build on the work together, and also paving the way that there's a lot more work to be done. So thank you for that. Thank you for an amazing lecture, and I hope everyone has a wonderful day.
Great. Thank you, Brenda. Thank you very much.